wanted.
All right, there we go. All right, good evening and welcome to Physicians Research Center's CERIUM Journal Club. I am Teresa Simon, the CEO of PRC Plus. Next slide, please, Jahan. CERIUM is one pillar of PRC Plus. It's our educational program designed for the busy healthcare provider who wants to understand cannabis and its derivatives through the lens of science. Next slide. We'd like to thank you for taking the time to experience CERIUM. It would be great if you could scan this QR code and participate in our quest to continually understand the healthcare provider we service and improve our programs. So, Jahan, I know that it's up now. Maybe we go back to it at the end as well if people don't capture it, right away.
Absolutely.
Okay, the next slide, please. The next slide is in support of our third pillar, which is the BUDS Info Analytics. This is our adverse effects data collection form. It's something that we've been sharing with patients, actually consumers and healthcare providers who do share it with their patients and anyone else who has tried or uses the hemp for cannabis. You can check out our website if you want to learn more at prc-trials-plus.com. All right, next slide. So joining us to discuss the paper this evening is Dr. Phil Molloy, rheumatologist, recently retired from clinical practice in the Massachusetts area. However, he remains very active in caring for patients, and he spends a lot of time on his bicycle, as you can see in the background. Dr. Jahan Marcu is a cannabinoid researcher who's worked in the cannabis area for almost 20 years. Next slide. And woohoo, I'd like to make a little bit of an announcement about Dr. Marcu with Andrew Peterson. They just published a book entitled Regulated Cannabis and Hemp Market Navigation, Business, Public Health, and Research Challenges. It's available through Barnes & Noble and Amazon. My copy is already coming in the mail to me. If interested, I can send you an excerpt or a section from the book. If you do purchase the book, we do ask that you rate the book through Barnes & Noble or Amazon. So now I'm going to turn it over to Dr. Marcu to start the discussion.
All right, hello everyone. Thank you for joining. Today we're going to discuss a paper entitled Acute and Extended Anxiolytic Effects of Cannabidiol in Cannabis Flowers, a quasi-experimental ab libitum use study. It's a very fascinating study with the lead researcher Cinnamon Bidwell doing a tremendous amount of work in this space. But before we dive into that, we're just going to take a little poll, little interactive session here. You will not be graded, but I'm going to launch this poll, relaunch poll, and just take a moment to fill out a couple questions. Number one, I have recommended cannabis products to some of my patients to treat their anxiety. Yes, no, I don't treat patients. Number two, I have never recommended a cannabis product to a patient for the treatment of anxiety. What cannabis product is best for treating anxiety? Spoiler alert, we're going to show some new data around this. Thank you so much for those of you who are participating and sharing your responses. This is anonymous. This is just for our journal club purposes to discuss and share among ourselves. All right, I'll just keep the polls open for another 30 seconds before we discuss this. I found that this paper was very interesting. It definitely aligns with a lot of stuff that's out there, but it also has some new insights that I wasn't expecting. All right, we have 8 responses in. Excellent. I'm going to now close the polls at this time. Oh, 9. Wow. All right. Excellent. All right, I'm going to end the poll and let's share the results, shall we? So I hope you can see these results on the screen. But all of you answered basically, I think, or 78% answered yes, they have recommended a cannabis product, and 22% said no, they don't, or they don't treat patients. 2 said, I would never recommend a cannabis product to a patient. 2 said yes, and 78% said no, they wouldn't consider that. 3 is what cannabis product is best for treating anxiety? A lot of people said THC CBD combo, very interesting. I think there's a lot of science there from earlier research to support that, but also for CBD dominant, and most of us would think, yeah, THC dominant, maybe not the best chances of efficiency for treating that. And overall, if you're here and you're learning about research, you probably feel pretty confident about the data. So that's great. All right. So let's move on. So with the next slide. So what is the problem? What is known about it so far? So in the United States, at some point, 100, there's an estimate that every year something like there's 100 million adults who will experience some form of an anxiety issue throughout their life. There are over 10 million active prescriptions for anti-anxiety medications. And surveys have shown that more than half of respondents who use medical cannabis report using it for anxiety. What is interesting is that there are anecdotal reports that cannabis can alleviate anxiety, and there are anecdotal reports that cannabis can worsen anxiety. And for the purposes of this study, when we talk about anxiety, we're not talking the casual anxiety of being nervous about the meeting with your boss, or you have an exam coming up. It's more of an anxiety that doesn't inspire you to address it or activate actions towards it. It impairs your functionality. Anxiety can be healthy. As they say, anxiety is the price we pay for being able to engage in long-term planning. And I don't know if you have anything to add on that slide for the moment, Dr. Molloy.
Well, if there's allegedly an evolutionary, it's survival advantage to being anxious a little bit. So it's potentially beneficial. When it's out of control, it's maladaptive and not beneficial and subtracting from your quality of life.
Right. It might be good to get a little anxious if you see a tiger walking towards you. Might be good,
Right.
right? That fight or flight response. But again, if it's having a negative effect on your function, it's not great. So with this type of study and this type of work, two important things to remember. There are huge differences in what we call cannabis products. And as a science guy, when I say a cannabis product, I don't mean a regulatory definition. I don't mean a marketing definition. I mean a scientific definition. Cannabis plant as a species, so it could be have lots of THC on it, lots of CBD, could have many other cannabinoids come in a wide variety of forms as well. And Dr. Molloy, as we discussed earlier, there are also major important patient differences with how they use these products. There's different mental health histories, there's genetic polymorphisms with how well people metabolize these products. So how did they design a study with all these variables? Dr. Molloy, do you want to talk a little bit about the study design?
Yeah, I'd love to. I think it's a kind of an unusual, I never saw a study quite done like this. Cannabis is an unusual product from a regulatory point of view, being Schedule 1 still. So it can't be studied in the same conventional ways. So they screened, by the way, a very large number of patients, like 16 or 1800, to end up randomizing a smaller number, as you can see here. They had significant general anxiety disorder, GAD, and they were currently already using cannabis products. They also had a control group who was matched with similar anxiety diagnoses and status of their anxiety that were not using cannabis. So they took anxious patients who had a diagnosis of anxiety who were already using cannabis products for their anxiety. They subsequently randomized those patients to three arms that you see at the bottom of this slide. Essentially, THC dominant, 1-to-1, THC CBD, and CBD dominant. And there are the definitions. And I think you can comment if there's anybody who has questions, if you would have done this differently. Does this strike you as representative of what your patients are using or not? But obviously this was chosen to shed light on a scientific question. If they're being helped or harmed by a cannabis product, is it THC or is it CBD? And in this study design would help you shed some light on that. The bullet above the second to the last bullet, the second to the last bullet, just tells you a little bit about how the study was conducted. There was an in-person, face-to-face follow-up at 2 weeks. The 4-week follow-up was done virtually on a mobile app. And there were numerous endpoints that we can go over later if you want. Anxiety is a common disease, mental health disease to study, and there are numerous validated anxiety tools used, and multiple anxiety metrics were analyzed, including subjective ones. How do you feel? Anything to add, Jahan?
Not at the moment, but I think as we dive deeper into this, I might have some questions about the products that were used. I think particularly, did they buy them all at licensed dispensaries? You know, that maybe we'll talk about that a little bit later, but that would be my thinking was, were there specific sites they bought them, or it's just, I know they had to be labeled, which was really interesting. And that brings us to the next slide is,
Yes.
we'll talk about some of the figures in the paper as well, but they had to have a labeled product. So it wasn't just a magical bag of cannabis flowers. It had to be labeled. And this part of this issue has to do with the Schedule I research issue. They couldn't blind the patients to the product they were taking. And I think that might become more and more of an artifact once cannabis is rescheduled. And researchers are actually able to conduct studies with products on the market.
I would like to add just something on the methods. They were bought at one dispensary. They had one participating dispensary who agreed to do this. I assumed that they didn't have to pay for the product. And I think that by the way, the volunteers got small compensation for their participation in the study, for their inconvenience, parking, driving, whatever. And the product and the study grant, or whoever paid for it, paid for the product. So yes, it was all labeled. That's a regulatory requirement in every state. The researchers can't dispense it because it's Schedule I. And they did choose one dispensary, and it's labeled, as far as I know, in every state. The third bullet, the staff that did all the evaluations was blinded. And I think we should go to the left and talk about the word ad libitum,
Oh,
because
yeah.
we saw
I'm
that
gonna think about-
in a
Oh,
previous study.
so where this is becoming more and more popular, I think, with cannabis studies or cannabinoid studies, is letting people use the product till they basically obtain the desired effect. And I think for inhalation, this is probably an effective way to pursue research studies. I don't know how well it works for edibles. Might take a while. But I think for inhalation or fast acting delivery, I think this is better than forcing someone to use more cannabis than they would normally use, or using less than they would normally use to achieve the effect that they're looking for. And that has often been a criticism of studies where they make people use these cannabis cigarettes that are manufactured for studies, and they might be too potent and people don't want to finish them, but the research protocol says you have to smoke the whole thing, versus the opposite can happen as well, where it's low potency.
I would like to just add that the obvious reason ad libitum is an attractive study design option is because if I am assigned to a group that is THC half of what another group has, I might just smoke twice as much. So to get around that, you have the ad libitum study protocol, and you supplement that with plasma levels of active cannabinoid products, which this study did. So and it sort of automatically helps you correct. I'm using half potency product. Am I just doing an end run by smoking twice as much?
And once they have people use the product ad libitum, they have to measure a couple things to see what's happening. And so they had some primary anxiety symptom endpoint measures. They had things including the General Anxiety Disorder Scale, the Beck Anxiety Inventory, and we're going to discuss in just a little bit the blood drawn at 4 weeks for plasma cannabinoid levels, which is very interesting to see what's happening across those different groups. Anything else you'd like to add, Dr. Molloy?
There was a subjective diary that people kept on an app on how high they were and adverse events, all that.
That is great. I hope they do a free text analysis on that as well.
Right.
So just as an overview to get a sense of this study, they had a 4-week thing, and they also had acute time points, right? So they have a baseline demographics with blood draws and physiological measurements and group and product assignments. And then they had a 2-week check-in and a 4-week check-in where they had to, slide on over to the clinic, or I think they had some mobile options too with the van that could come to them. And they had some pre-use and post-use effect monitoring. And so I think we've covered the methods and design pretty well. So let's go into the first big data. We're going to jump all the way to figure 3 of the paper because we've kind of outlined figure 1 and 2 here. We're happy to share them at the end, but in the interest of time, let's first talk about these scores, these patient global impressions of change, these PGIC scores. So the observer always affects the experiment. So across all groups, they report improvements in anxiety over time. So in this orangish yellow top here, this is the 1-to-1 group. That is the THC CBD group. We also have blue is CBD, and this reddish orange, we'll call it red, is the THC dominant, and this dark blue, not to be confused with CBD, is the non-use category. And so we definitely see that the groups that were receiving cannabis products showed greater improvement. Similarly, the groups receiving cannabinoid products had anxiety levels decrease from baseline to the end of the study. The CBD group showed the greatest reduction among all of them, shown here in blue at the bottom by 4 weeks. But there were no significant differences for these estimated anxiety scores over time. Dr. Molloy, any comments?
Oh, it looks like there's no overlap between the blue and the red. So it looks like there's a 4 weeks. It looks like there's a statistically significant difference in favor of the CBD dominant group. That's what just visually it looks like. I forget if it met.
It does appear that it is a significant difference, especially there might be some members of that CBD group that did experience it.
Right.
Absolutely. But it might depend on what type of CBD product they use, whether or not it had THC in it or something like that.
Well, the blood test will show that.
Well, let's bring up the plasma test. So here are the blood cannabinoid levels. So again, in this fire engine red, at least on my computer screen, is the THC group in the top right corner on panel A. We have a THC CBD combo group in the yellow, orange, and blue CBD here. And this is, again, the amount of THC nanograms per milliliter. And we also have a blue non-use line. So when we see this, what's interesting is it is an ad libitum study. People are using products to get the intended effect, but yet it almost looks like like they were like dosed in a regimented way because of this, except for that CBD group, where we see increasing amounts of THC pre-use and post-use. So what could explain this? I can think of maybe 3 things. So it could be trace amounts of THC in the product. If you go to a licensed dispensary, they sometimes sell hemp products as well because they don't have to be tested and all this other rigmarole that is required for something called a cannabis product. So there could have been something like that. There could be a small percentage of THC even in the CBD dominant product. They could have been a regular cannabis user and been abstaining from use. And then when they're getting tested, it just happens to be a time when there's more THC being released from their adipose tissue or fat tissue. As you know, you can test positive for THC weeks after your last use, especially if you are a regular user or regularly exposed to it. And I think, Phil, any comments or questions on this slide?
Well, yes, my only comment is, I think you and I mentioned this before. You trust the labeling in licensed dispensaries because allegedly the blue product on the line had pretty close to zero THC contained in it, certainly under 1%. So it surprised me to see that slope go up. I mean, that is what surprised me on this graph.
So,
And
yeah, I
yeah,
mean, if
how
it
do you
is,
account for that?
so
Yeah,
I would say if it is through a regulated store that use a licensed and accredited laboratory for the labeling,
right.
I would trust these results. But it doesn't take much THC to trigger a positive on a urine test. You could have, 0.3%, could be a significant amount of THC when you're talking about 1 gram or 2 gram or an extract, a concentrated extract that is being inhaled. A 5 milligram, a 5 gram gummy bear could still have, over a dozen milligrams of THC on it, for example. So
Yeah,
again, if this is a CBD flower, it still could be producing small amounts of THC, perhaps. The reason it's
right.
called cannabis is that it's not hemp. It has 1% THC on it. So I think it could be just from that. If it is
Well,
inaccurate labeling, we have a bigger issue.
yeah. Well, overall, except for the upsloping on the blue line on graph A, this validates the three arms of the study. One had a ton of THC, one had a ton of CBD, and so forth. And so this is what you would expect. It validates the study design.
And then likewise for B, the THC group had
Right.
no CBD there on the bottom, the orange and the dark blue. And so moving forward, this is sort of the should be figure 5 here, the subjective drug effects and mood changes. So there are 4 panels to this, and the first one is looking at positive mood scores. So positive mood increased post-use for all cannabis using group. The non-use group did not show significant changes in positive mood. So THC, CBD, THC, or just CBD dominant products, positive increases in mood that were significantly different from baseline. Tension is another score that they looked at. And again, the non-use group did not experience changes in tension, but everyone receiving cannabinoids did see post-use changes. So I think these are probably what we'd expect. At least I would hypothesize that if people are able to use a cannabis product ad libitum to reach a desired effect, their desired effect is probably not an adverse effect. And so I would imagine they would use right to this point, which I think helps to validate the study design.
Good point.
And we can come back to this one, Dr. Molloy, if you want to make a comment, but I wanted to go to the next one because this for me was a very interesting slide. So figure 5C talks about paranoia, and paranoia is different than anxiety. I mean, sometimes I guess they're melded together when people talk about them, but basically for paranoia, the ratings for the patients increased in the THC and the THC CBD groups, but the CBD dominant group and the non-use group did not show changes in paranoia. And I think the important reason that we may have seen this is because it was an ad libitum study. We typically don't see that with some of the THC CBD extract studies in the past, but those were tightly controlled with dosing and maximum dosing thresholds. As far as subjective drug effects, how I guess zonked people are feeling, the THC dominant and THC CBD groups showed more increases compared to the CBD dominant group, which I think we would also anticipate potentially from an ad libitum type study.
You know, paranoia is a funny um, adverse experience reported anecdotally forever with cannabis, it seems. And one might postulate that the slopes weren't even steeper positive because it was ad libitum and people would stop using it if they got too paranoid. But you've heard stories about people describing paranoia from cannabis use forever, probably. There's very little objective research on that particular angle in the literature.
Yeah, I would agree too, because I think sometimes the study design can be more likely to increase it. There was even one study where they were injecting people with THC and the fire alarm went off, and that guy threw off the whole study because he thought that they had done it on purpose to mess with him. So there's been some issues with previous studies that have looked at paranoia from an acute exposure of THC. So this study, I think, had a lot of great aspects to it. And many, I think some of the weaknesses of it are potentially a direct result of regulatory issues that they're trying to navigate. But this is the first randomized study that is assigning patients to different groups to look at acute short-term effects and long-term or extended effects of ad libitum legal market cannabis products on anxiety symptoms. And I know, Phil, you wanted to talk a little bit about some of these next bullet points.
Um, yeah, the second bullet point seems to just be self-explanatory. I thought the endpoints were really, um, I thought it was really a well done and thought out and thought through study. The multiple anxiety metrics used, the blood tests, the subjective symptoms, the diaries. I thought it was really good. This is the first paper I recall ever reading and I'd like to know if anyone in the audience has ever heard that or seen the word quasi-experimental in a study title before in a published article. Because I don't know what quasi-experimental mean. I know what randomized mean, and this was randomized. It was single-blinded and randomized and prospective. Quasi-experimental, I suppose, means that they used off-the-shelf legal cannabis product, maybe.
So as we near the end of the data presentation, we can open up for discussion. I really thought this quote was great from the paper. So in the author's own words, accounting for frequency of cannabis use, the greatest reductions in anxiety were found among those using CBD dominant cannabis. And another thing the authors discussed was that more frequent cannabis use was associated with higher levels of anxiety at baseline, which is consistent with broader associations between frequent use of cannabis and negative effect. So in summary, the article's authors found a number of interesting things. So for CBD dominant cannabis, this is not a purified CBD product. I'd like to emphasize that. They found significant reductions in tension and paranoia shortly after use. That group had the largest reductions in anxiety symptoms. They experienced increased positive mood and fewer negative mood effects compared to those using THC dominant or a combo cannabis product in this study design. THC dominant cannabis products also increased positive mood, but there were slight increases in paranoia and tension compared to the CBD group. All participants, including the control group, reported improvements in anxiety symptoms over the 4-week period. More frequent cannabis use was associated with higher baseline anxiety levels, but what I think is interesting is the data implies that CBD dominant cannabis products may be a more effective option than THC dominant cannabis products. There's been a long time rationale from the basic literature that CBD could be a great antipsychotic drug or an anti-anxiety drug based on animal studies and some anecdotal reports, but this is the first, I think, off-the-shelf study that has really looked at this in a very objective way. Any thoughts on this, Dr. Molloy?
I think in an ideal world, if you had to start from scratch and write a study design again, a better study would have been to take users because it's probably ethically, there's probably some issues in taking non-users. Um, but I would take the same population, people with anxiety who are using cannabis, and I would randomize them, and they would come to the clinic, and it would be double blind. They would get products that they wouldn't know what was in. And it would be the same three products. They would get it from me as a researcher instead of go down the street to the dispensary and get it. I think that would be a better study design, but you can't pull that off with the regulatory environment.
Excellent. Well, it looks like we do have a question. If we're ready to open it up, we just have some closing slides and announcement. We can open it up. Dr. Sadari, welcome to the Journal Club.
Yeah, thank you for having this evening. I was the second doctor in the state of Ohio to, since 2016, when it became medically legal in Ohio to register people for cannabis. And I guess maybe I missed it or didn't, maybe it wasn't discussed. When you're saying CBD dominant cannabis that has THC in it, what were the ratios when you were saying CBD dominant? How much CBD to the THC? Thank you.
That's a great question. That is a bit of a head scratcher for us, as they say. So if we go back to look at the data, so I'll just go back real quick here. I think it was here. When we look at the THC levels in the CBD group, let me see if I can use a laser pointer here. Let's hope for the best. All right. So with the CBD group here, we can actually see that the THC nanograms, that there was something in there. We don't quite know if it was trace amounts in the product. We know that the products were labeled. Dr. Molloy, if you have the paper handy,
It's on slide 11, I think. The
it says,
exact percentages, that's a great question. And am I right? Is it slide 11?
oh, slide 11. Yeah, let me go. Okay, yeah. There we go.
There it is. Yeah, the THC dominant had 24% THC and less than 1% CBD. The balanced one was 12% and 12%, and CBD dominant was less than 1% THC and 24% CBD. So very distinct products. Again, licensed and labeled in Colorado.
And you also, one more comment, on being zonked, so to speak. I have learned, maybe inaccurately so, that the level of CBD, usually the lower levels of CBD, like 10 milligrams, 15 milligrams, can be energizing, where higher CBD, like 25 milligrams, you see over the counter, CBD that's allowed over the counter has like melatonin and chamomile added to it because higher doses of CBD can, relax you, et cetera, or maybe even zonk you. So that's another thing too. Thank you.
Thank you.
That would be a good study to do.
Oh, and great. We have another question. Thank you, Dr. Sadari. I hope I'm pronouncing that right. And Dr. Viner, am I saying that right?
Yes. Hi, how you doing?
Hi.
Great. Great article and presentation. I had a couple comments coming from a psychiatrist's point of view. The generalized anxiety disorder, I'd be a little concerned how they verified that diagnosis, because most of my GAD patients don't like cannabis. Of all the anxiety disorders, they get too worried about using it. So I haven't seen it help a lot of patients with GAD, but maybe other anxiety disorders like associated with medical problems or panic attacks, or there's social phobia. There's all kinds of anxiety. So anyway, that's interesting. The scales they use aren't that robust. I haven't heard of some of them, and I do psychiatry research. It's good they did the HAM-A, but I'm not too impressed with the rating scales. The paranoia can't really be reported subjectively, in my view. It has to be measured. So there's a lot of blame for cannabis causing paranoia, but a lot of it doesn't really pan out from a strictly psychiatric definition. And the dose of the CBD, or in the CBD, that was a good point the doctor made. I find that this THC is more uplifting and CBD is more sedating at the higher doses. So it can, that's why it helps the anxiety. But what I get worried about is nobody monitors for safety. Most of the safety issues are well beyond 4 weeks if you're using high doses of CBD, like the changes in the body and inflammatory markers and stuff. Like what happened with the Epidiolex. Most of the psychiatric, the depression and somnolence, sedation, and suicidality, they studied all that was months after the acute study phase of 4 weeks. So I would be careful when my patients are doing CBD for anxiety. I watch for depression. It's just like anything else, like a benzo. You take too much Valium, you're going to get depressed. So if on the high dose they're using it for anxiety, I really feel depression has to be monitored closely, and you got to stop it or lower the dose of CBD if they start getting somnolent, sedated, lethargic, anhedonic. So really, you got to look at the type of anxiety and depression the patient has when doing CBD. But the THC can also help some depressive symptoms. In fact, the renal doctor this year presented a grand rounds where the THC was used to help depression. So it's uplifting, stimulating. So you got to use both too. Using a monodominant product to me is dangerous. You're just taking out the active part of one, and you monitor clinically for side effects. But anyway, thank you. I enjoyed the talk.
Thank you. I think those are all great points. Dr. Molloy, go
Yeah.
ahead.
No, I was going to say again, thank you for those very thoughtful and insightful comments. The only entry criteria was self-reported diagnosed anxiety, and then they administered the GAD-7, and they had to score at least 5 out of 7 at the first visit. That was how they got in. Self-reported diagnosis and scoring 5 out of a scale of 1 to 7.
And yeah, and I particularly appreciate the comment about the long-term use of CBD. I imagine that probably for safety reasons, that's why the study was approved or for 4 weeks, perhaps. But I think I really found that interesting, the comments about long-term CBD use and monitoring some adverse effects that I think are often underappreciated with that. Really great insights. Dr. McDonald, you've been waiting patiently with your hand up. Did you have a question or comment for the group?
I have a comment. I'm a psychiatrist who's in Canada, and I've been prescribing medical cannabis since 2016 for not just psychiatric issues, but for any issue, actually. And I have had people on CBD high doses for as much as 8 years. The trick is that you've got to know what other medications they're taking and make sure there's no interactions either on the same pathway or through the CP450 system. And of course, look at their overall general health, because if they have some other underlying problems, you've got to be really careful, and you have to work with their other doctors to make sure, and pharmacists, to make sure that if there is an interaction found, that if the CBD is working, that the other medication is either reduced or increased to the appropriate level. My other question is about the CBD THC. I gather it was all herbal and smoked. They kept a diary. Did you include that diary information as to how much they actually were taking.
Great question. Let me see if it's, I don't have the supplemental
Yeah,
figures open, but we could definitely post that. We usually write blogs of these articles and put them on the website, so we could put that as a great follow-up to this article to see if they mentioned that. Dr. Molloy, do you know off the top of your head if
No, I
they?
can't. I don't remember. No.
All right, let me see.
The reason I was asking is because if they used a lot of the CBD dominant and used a lot more, even having less than 1% THC in there will accumulate. I mean, it has a 72-hour half-life,
Mhm.
and you only studied it for 4 weeks. So that could be part of the reason for showing that high THC. Anyway, thank you very much. Excellent paper.
Thank you.
Thank you. That is a great comment. I'm gonna see real quick if I can get that. Yeah, I know I need to log into my university here. But it'd be great to see if I can get that supplemental data at another time. I have to be more thorough with these journal clubs. Got to make sure they have 6 supplemental figures that aren't directly attached or linked to the article that you have to go to the original publisher, log in, and download. I'll take a look at those. And for our write-up about this journal club, which will go on the PRC blog space, I'll try to address that. But also great questions as well. And I agree completely with the CBD. There's a lot of factors there. I think there's a lot of DDI studies about CBD as well, and what it can interact with. And so I think that's was one of my passions for a few years, was researching drug-drug interactions with potential cannabinoids. And Penn State, I worked with them for a little bit on a project. They actually have a website, I think it's called CanDir, like Can Directory, CANDAR, where you can put in drugs and look for adverse event reactions. But there's a number of tools available for that now. All right. Well, we are upon the 8:47 mark on Tuesday. I think we've got a lot of great quality questions from you health professionals. This is why we do it, is to encourage this sort of discussion and share this research. So I'm going to just, of course, we're looking for any last minute questions, but I'm going to just skip to the end here. And don't worry, I know what screen I'm on. So let's see. All right, so just zooming through, there's an additional resource here that Dr. Molloy shared with me. The Helio launched a special report on cannabis. We will be uploading this to our YouTube page and sharing it. But again, if you want to look up the Helio special report, there's some great summaries there that come to similar conclusions as these researchers. Please consider signing up to get notifications about this journal club and things like our blogs and stuff like that. For the next 3 months, August, September, October, first Tuesday of every month, 8 p.m. Eastern, we're going to be doing a series on different standalone research articles on topics of pregnancy and development. So it's just going to be a 3-part journal club. We've reached out to some colleagues of Teresa Simon and Phil Molloy who study this area, work in this area. So we're expecting a big influx of experts who work in this area of sort of prenatal education and things like that to participate as well. But we'll be taking 3 current studies and just kind of doing that back to back to back. We also, in the future, would welcome any recommendations for topics, but we do try to pick current articles that are out there to discuss and share with you. So the next 3 months are all going to be about pregnancy and development, everyone's favorite topic. As a former baby, I am interested in it as well. All right, Teresa, any other announcements for the moment?
yes, just one more. So just that I think that you can attend one of the 3. You don't have to do all 3. That's just a matter of clarification. Just be sure that everyone doesn't think that they have to participate in all 3.
Right, you could attend the the October one only if you wanted, but you'd be welcome to attend all three. You'd be
Yeah,
uh,
I think
very,
it's more
very.
about, yeah, it's more about availability, and all of them will be on the website, right? We record all of them. So if you miss
Excellent.
one, it'll be available.
Great.
All right. All right. Well, thank you so much for your time today, everyone, and I hope to see you at the next Journal Club. We'll give you 10 minutes back on the hour.
Sorry to interrupt for a second. You were going to show the QR codes at the from the beginning at the end as well.
Oh yes, we can do that. Yes, let me get to those. No problem. Thank you. I appreciate that. We'll go right back to it. So this is the questionnaire, and and then the next one is a data capture tool that Teresa has put through her network of physicians in their clinical offices, just to collect anonymous data for signal detection about adverse events. And we've done some research posters and stuff like this about what we found so far with some of the trends. But this is for the questionnaire, just to give us some feedback. And then the other one is this. This is a free public tool. Teresa works with a lot of students. This was actually a bootstrap student project with a mixture of undergraduates and graduates that put this together and have continued to reiterate it. And it's worked out really well. We've gotten hundreds of scans. We've actually probably could go toe to toe in number of interactions with any other federal, surveillance program. I mean, we're talking like for cannabis products. I think it's pretty impressive.
So feedback is welcome. I mean, if you think that we are in the process of trying to improve it, but I always I look forward to having conversations about improving.
Great.
Yes, thank you everyone for participating. We look forward to seeing you in August.
All right. Yeah.
All right. Well, I will be signing off. We know you have a variety of journal clubs to choose from. We thank you for choosing PRC. All right. Have a great night. I hope to see you all soon. Thank you so much.